Okay, we are looking at a very complex cranial nerve here. If you don't know the name of this cranial nerve, you should go back to your advanced levels. I mean, you should not be a medical student. This is the seventh cranial nerve, or the well-known facial nerve. The facial nerve has three different nuclei. You have the parasympathetic nucleus, we call superior salivatory and the lacrimal nucleus. Then you have the sensory nucleus, the nucleus of tractus solitarius. Then you have the motor nucleus. Okay, there's a special story about the motor nucleus as well. When we are talking about the nuclei, the parasympathetic nucleus, the superior salivatory and the lacrimal gets supplied from the hypothalamus, and also it gets supplied from the trigeminal nucleus. Why for lacrimation? If your conjunctiva or if your eye is irritated, you have to show tears, of course. Then from the trigeminal sensory nucleus in the pons, you get a supply to this particular fellow. So the motor nucleus, the important thing is, I think you already know this one. The upper half of the motor nucleus gets supply from bilateral cortex, but the lower half gets supply only from the contralateral cerebral cortex. Only from the contralateral. So if you have even a cortical lesion, you will have a facial nerve palsy involved in the lower half of your face. Okay, then once this comes out of the pons, it comes out at a special place we call the cerebellopontine angle or the CP angle. This is actually the junction between the pons and the medulla. So it is from the lower pons that this arises, and from the junction of the pons and the medulla, we call it the cerebellopontine angle. So from the cerebellopontine angle, as it comes out, there are two routes. One is the sensory route. This sensory route is now from the NTS. This sensory route is combined with this particular route, the parasympathetic route. So both these two together we call the nervus intermedius. Then you have the other route, the motor route. So all these three routes, I mean this combined nervus intermedius and the motor route, are going in this particular canal. We call it from the posterior cranial fossa, it's going through this particular canal. We call it the internal auditory canal or the internal acoustic canal. Another person, there's an intruder, which is the 8th cranial nerve. Your 8th cranial nerve is also accompanying this facial nerve in this particular internal acoustic canal. It's important when you think about the lesions. Then from the internal acoustic canal of the internal ear, it reaches this box. This box we call the middle ear. The junction between the box, the middle ear, and the internal ear, you have a genu. This genu is like a bend. That's why we call it genu. What is this genu? This is because of the geniculate ganglion. Now remember, geniculate ganglion is actually the ganglion of your sensory nerve. The nucleus tractus solitarius, the sensory nerve. Okay? Then the parasympathetic fibers that come to this particular genu or the junction divides into two. The one that provides your tears will go up. The tears will go up. But the ones that makes you salivate when you see food, this one has to come down. Obviously, your eye is in top, it goes up. So this separation of this eye and your greedy salivatory nucleus, this separation of your emotional tears and greedy saliva occurs at the genu. So your emotional tears goes up through the greater petrosal nerve and forms the ganglion, the pterygopalatine ganglion, then the lacrimal gland. It innervates your lacrimal gland. Then this particular fellow, the other one that separates, is going along with this particular canal called the facial canal. Is going together with the rest of the nerve. What is the rest of the nerve? The rest of the nerve is, you have the sensory fibers and you have the motor fibers. So these are going, of course the sensory fibers forms the cell body here. Actually sensory comes from the other way. So you have this particular ganglion, geniculate ganglion. So then this genu or the bend, then all three are going like this in the facial canal through the medial wall to the posterior wall of the middle ear. In the posterior wall it goes halfway and the motor nerve gives a branch, the nerve to stapedius. After nerve to stapedius, another special thing occurs. These three people who came together decide to divorce. So the mother or the sensory nucleus is going away along with the child or the parasympathetic. What is the name of the mother? The coda tympani. So the coda tympani along with the parasympathetic supply from the salivatory nucleus is going or separating from the middle ear and exiting the middle ear and going here. So the chorda tympani will get supply from the anterior two-third of the tongue, whereas the child, the one who got separated along here, that is the one which provides your greedy saliva. It goes and forms a ganglion, the submandibular ganglion, and supplies the two major glands, the two major glands, submandibular and sublingual glands. The other person, the sensory person, goes to the tongue. Then the motor person, who is now alone in the facial canal, comes out of the facial canal through the stylomastoid foramen. Now it is out around here. So then from the stylomastoid foramen, it gives 5 terminal branches, which we all know. It also gives the posterior auricular branch, the nerve to posterior belly of the digastric, and the nerve to stylohyoid. Remember who gave the anterior belly? The trigeminal nerve. Okay. So this is it. Then it gives the temporal, zygomatic, buccal, marginal mandibular, and the cervical branches. So this is basically the pathway of the facial nerve, which seems to be a little bit complex, but you can understand. So depending on this, where it gets damaged, if it gets damaged in the pons, it has different lesions. If it gets damaged in the interlocustory canal, it has different lesions. So we'll see. Now, regarding the lesions, we can divide them into upper motor nerve and lower motor nerve. Now this green box is the clinical manifestations. So when it comes to the upper motor nerve lesions, we know that lower half is only paralyzed, upper half is okay. So you have the wrinkling. Sadly, you have the wrinkling. Your eyes, yes, you can close your eyes because upper half is okay if it is upper motor nerve lesion. But the lower half, you have the drooping of your mouth. But remember, emotional movements does not involve your motor cortex. It is something does not involve, it can be intact here in your upper motor nerve lesions. Emotionally, you can smile. But lower motor nerve, everything is gone because it's the lower motor. So lower motor nerve lesions can start from the pons where you have the nucleus. Okay, the nuclear lesions. So we know when we're talking about the abducens nerve, we told that the abducens nerve is in close proximity with the facial nerve. If in the pons, if your facial nerve gets affected, usually your abducens will also get affected. So that means here you have a 6th cranial nerve palsy as well as the 5th, because in the pons you have the sensory nucleus of the trigeminal. So all will be affected. Then you have when it's coming out, when the roots are coming out, we told that all the roots are coming out in the CP angle. CP angle tumors, there are some special tumors called schwannomas. We call them acoustic neuromas. These acoustic neuromas, these tumors can compress the 5th cranial nerve, more than the 5th, the 6th, the 7th, 8th. 6, 7, 8 can be compressed by these acoustic neuromas. These are tumors. Then in the internal auditory canal, if it gets affected, it will get, if the facial nerve also affected, 8th cranial nerve also is affected. Then at the stylomastoid foramen, when it is coming through a narrow space, if your nerve gets swollen because it has inflammation because of an infection, maybe herpes zoster like shingles, like in the trigeminal, Ramsay Hunt we call it, or as if it is herpes simplex virus or in Bell's palsy. So these are all lower motor nerve. Anywhere, other disease conditions can also affect. You don't need to know them in detail. However, remember how the upper motor nerve lesions are different from the lower motor nerve lesions. So these are the things that will happen. Loss of the frontal wrinkling, you cannot close your eye, you have the Bell's phenomenon where your eyeball goes up, the pupil goes up. Then you have the loss of the nasolabial fold, the mouth deviates to the normal side. You can do the corneal reflex to see. You will have hyperacusis. So these are the things that you will have. Why you have hyperacusis? Because of the nerve to stapedius. Nerve to stapedius will stabilize your stapes bone. When your stapes bone is stabilized, it will reduce excessive vibrations of the tympanic membrane. So remember, if your nerve gets damaged here, before it gives all these things, it will affect this one, that is nerve to stapedius. It will affect all the motor things. It will also affect your taste sensation. It will also affect your parasympathetic. You cannot salivate. But if it affects here, salivation, taste sensation, hyperacusis, none of them are there. So in Bell's palsy, where it affects here, you don't have hyperacusis, you don't have salivation issues, you don't have taste sensation issues because it's affected here. If it is affected here, then you have salivation issues, but you don't have hyperacusis because it's already given. If it is affected here, you have hyperacusis, you have salivatory, taste, all. So that is how you must know about the anatomy. So that is it for the facial nerve.